So, hello. It's a really great day for me because I have a great guest for you. I want to introduce you, Peter Malliaras. Peter, thank you. It's great to having you. Thank you. You agreed on this conversation. Can you tell us a little bit about you?
Thank you for having me on. So I am a physiotherapist. I've been practicing for 27 years, and I now am. I've always done a mix of clinical and research practice, and now I work 1 day a week in a clinic, and I work also as a full-time professor at Monash University, where we do research with students in many areas of many topics of tendinopathy,
Uh,
mainly Achilles and shoulder at the moment, but we're interested in biomechanics, in trials, looking at new treatments, so various PhD students and funded research, which is keeping me busy enough at the moment.
mm. Can you tell us, do you work only on the research or do you also teach students?
So my job is mainly research. I do a bit of teaching. I do, say, for example, the tendinopathy type lectures within the student syllabus, but I also do research methods, which I really enjoy to the students. So I teach them
Mhm.
research methods. So that's all my teaching, but it's very minimal. It's maybe 1 hour a week or something like that.
Okay, so mainly research, mainly
Mm,
research.
mm,
Okay.
mm.
And you said you're teaching, which you really enjoy, methodology of research, yeah, research
Yes,
methodology. Can you
yes,
tell
yeah.
me how long or how many blocks or years your students do have those subjects?
They have it throughout their whole 4 years. So the undergrad program, they'll have some research methods throughout the whole time. So they'll do a bit in first year, second year, third year. Then they do a project in fourth year where it all
Mm-hmm.
comes together, knowledge, and then they have to do their own research.
Yep.
Because they have all of our students, physiotherapy students at Monash, they will can't finish with an honours degree. So
Yep.
that means that they've done an honours level research. So it is a good it's a good degree. So if there's anyone near in Poland interested in doing physio at Melbourne, think about Monash.
Okay. Okay. Good advertisement, of course.
Yeah. Why not? Why not? I thought
All
I'd throw
right.
that in there. Why not?
Can you tell me how it happened let's say, finish in tendinopathy problems? I mean, you're very well known in research in this topic or about this topic. How it came you are here?
Well, I think just it just happened naturally without any planning, without any sort of. It just happened to be that I was working and was then working with people who were working with a lot of tendon patients, and then working with people who are researching in tendinopathy in Australia. There's been a lot of research in tendinopathy going back many years, many decades now, and I was in the same place at the same time,
All
and
right.
it was just luck. So it was just the luck of meeting those people. Then I started having a very strong interest in that area. So
Okay.
I think it was more luck than anything else, planning or anything else.
Okay. And tell me, please, when you have been a student, have you been interested in research also? It was from the beginning or it came also?
Yeah, I was very interested in research right from the beginning. So even when I was in my undergraduate, I was very keen on research, and I just always wanted to understand how things worked in a deeper level. And that, I think, then led me to do my honors. So I did a project which was about a year where we did some research when I was an undergraduate, and then that allowed me the way the system works in Australia is if you do an honours, you can then go into a PhD after.
Uh,
So that allowed me then I went and worked for a few years. I went when I finished my undergraduate, I worked for 3 years, and then I went back and did my PhD after that.
okay.
Um, yeah, so the honors allowed me to get into the PhD.
All right. So when we are already in tendinopathy world, so can you please, in your words, define tendinopathy? So what is the definition of tendinopathy in your words, in your mind?
Yeah. So tendinopathy is really basically just pain. It's a condition that is characterized by pain in the tendon, as well as usually disability or some dysfunction in the ability to do things in daily life, like walking, running, using your upper limbs if it's an upper limb tendinopathy. So that really it's pain and dysfunction, but it can also be having an element of pathology in the tendon. So there are changes in the tendon that occur as well. But the current definition is, and the current terminology that we use is tendinopathy, not tendinitis. So we had a consensus of experts recently that where we agreed that we should use the term tendinopathy, not tendinitis, because tendinitis is, sometimes people think that it's inflammation, and that's maybe not so clear in the evidence at the moment. We know that we're still trying to understand what's happening inside the tendon. There could be elements of tendinitis. There could be elements of other things going on. So it's not clear, and therefore using the term tendinitis is not recommended. It's also not recommended to use that term because sometimes people think it's just inflammation. All I need to do is maybe take some anti-inflammatories and it will get better. And we knew that that's not the case with tendinopathy. So therefore, it's also not a good idea for that reason, because that's what we used to do, say in the 70s and 80s, when people thought it was inflammatory. They used to inject steroids and do anti-inflammatory oral, and that was it. And it didn't get better. So that's why we think it's important to define it as a condition where it is based around pain, persistent pain. It's a persistent pain condition that also involves some disability.
I see it also as a purely clinical diagnosis, mainly.
Yeah, exactly. And
that.
that's the other really important part of it. It's the diagnosis is made on completely clinical grounds. So it's not right to diagnose tendinopathy based on a scan. You can't do it. You can only say that someone has tendon tissue changes or pathology on a scan, but they might be age-related normal changes that are not painful. So you have to have an element of pain to have tendinopathy. So I think that's where it's important to and that sort of then goes into the whole, pain versus pathology, which is we know there's a difference between those two. Some people have pathology, but they don't have pain. And that's quite common. It's common to have pathology without pain. So we need to be very careful not to diagnose based on just the pathology. Sometimes we can use pathology to help our diagnosis, to make it more to confirm diagnosis, and sometimes it's useful for differential diagnosis as well, using the scans.
You already mentioned inflammation. I will try to come back to that, but I think we fluently went to some maybe etiology or pathomechanisms, because from my perspective, what I know for now is that we've got some hypotheses like Cook and Purdam, so continuum model, or Fu model, or Millar model. There are many of them, at least 5 very well known. And
yes,
how would you summarize those things? I mean that we see that the problem is very wide. This is not only young people and active. This is whole range of people.
Right.
maybe not 10 years old, but sometimes they are.
Right.
And that's another story.
Right.
But can you tell us a little bit more from your
Right.
perspective about it?
Yeah, for sure. I think it is complex, as you say. There's lots of different models. There's lots of different theories about what causes tendinopathy and how it comes about. We know there are some things that we think contribute to tendinopathy. So things like, for example, load and activity. So if you do too much activity, and that's the continuum model. The continuum model talks about loading and overloading, and then various changes that happen in the tendon if you do that. You've also got then a lot of those models, like the ones you talked about. They will then talk about some of the pathophysiology, some of the changes that happen, signaling changes from the tenocytes that happen within the tendon. And there's lots of cytokine changes and lots of things that happen then to cause pathology and pain. The Miller review that you mentioned is a really good one, because that really is comprehensive and covers all those different changes and all the different systems within the tendon that can happen, and that can lead to pathology and pain. So we know there is a lot of things happening in the tendon from a pathophysiological point of view. So if people want to read up on that, the Miller review, which was published in Nature Reviews, is probably the best one, the most current one. But I think from a clinical point of view, all that stuff doesn't help us that much.
No.
Because it's just that's just understanding all these biochemicals and all these different things that happen, which are very theoretical. And maybe in the future, there will be drug targets for some of these things that happen. But at the moment, we don't have good drugs that can target the pathophysiology. We just don't have that at all. And we don't, and therefore we have to take a step back and think about how we're going to treat these people. And it's really based on, it's really based on more so looking at the person as a whole. So the way that I tend to think about what is contributing to a person, I try and think about it on two levels. One, what's contributing to the tendon pathology? So we know that there are certain things that can cause or contribute to tendon pathology. These are things like age. They're things like the loading that we talked about already. They're things like hormone imbalances, so people during menopause. They're things like, elevated BMI, people that are, got general health problems like cholesterol, elevated cholesterol, diabetes.
So metabolic things, yeah.
Yeah, exactly. All the metabolic factors. So all these things can contribute to a tendon problem. And they can then, if you think about the pathway, all these contributors can then cause a tendon to change. But just because, and this is what I tell people when I'm talking and lecturing about tendinopathy, just because you've got a tendon, you've got lots of tendon risk factors, it doesn't mean you're going to necessarily get pain. So pain is the next level above that. The tissue might change, but you may have a tendinopathy in the tissue, but never experience pain at all.
Yeah,
and that's quite common as well.
This is another factor, because we've got people who are, from pathologic point of view, very ill. From functional point of view, very often very ill, because they've got dysfunctional, for example, I don't know, plantar flexors, for example, and they've got very bad metabolic profile, but they don't have pain.
Yes, exactly.
And we have, at least I don't have, any biomarkers which can tell me you will or you will not, and when. So, I mean, the judgment of the risk is just like a magic ball, trying to to read from the magic ball.
Yes, exactly. Yeah. It's what's it called? I'm trying to think of the crystal ball. Crystal ball. Yeah.
I always say Dumbledore. Dumbledore.
Yes, exactly. Yeah, that sort of thing. Yeah, I absolutely agree. It's the same with all risk. You just don't know what's going to tip someone over to pain. And that's when you then start to explain all the pain risk factors. And the pain risk factors, as we know, is all of the biopsychosocial risk factors that we have. So someone can be susceptible to tendon pathology with the usual tendon risk factors, but then they tend to deal with that. They tend to deal with that well, and they never have pain. But other people, because of other factors, susceptibility to pain, and that's all the biopsychosocial factors. So, how well they're sleeping, some genetic factors, some psychological, social factors, how they think about their pain, how they respond to their pain, how they cope. All those factors will then change susceptibility. So it is very complex. So you've got to think about it, because it is a persistent pain condition. It's not just the tendon and what's happening at the tendon level. It's also pain. And that sort of explains that lack of relationship, or lack of really good relationship between pain and pathology that we see.
Yeah, when we look into statistics, of course, they are very different, but we see that when we talk about loading, tendon loading, which is, we can say, I hope we agree, it's a primary method of treatment, or at least it has to be there. Somehow it has to be there. Do you see that there is a group of people, and it's not very small, that they are not responding well?
Yes. Yeah, I think that's true. So I think the way that I think about the management is, yes, it's true that tendinopathy is a load-related condition. And at some level, there needs to be load to overcome it, because it is a load-related condition. So you need to be able to load the system. But load can be in many different forms. It might be sometimes you've got an Achilles patient doing calf raises, or it might be just running and getting people to do walking or running. So it doesn't necessarily need to be therapeutic load like calf raises or anything specific. But I think being able to provide a pathway to recondition and reload the tissue in a gradual way is probably the most important thing, I think, in management, and trying to then replicate the loads that person needs to do in their daily life, and give them the confidence to be able to do that, and the right understanding of the pain. That is probably the most important thing in management. But there are people that you do that with, and they still don't respond to that treatment. So then it becomes difficult, and then you start looking at the contributors again more. So then we start thinking, okay, we've done the loading. Is there something else? Are they understanding the problem well? Are there other contributors from a hormonal or metabolic point of view that I need to target? Are there other things? Are there genetic factors? And obviously we can't test for genetic factors, but we can ask them about their family history and other things as well. So
we can test genetic factors, but it would be very costly.
we probably can these days. We probably can, but it would be costly, and also we sort of think of the certainty of that information as well. Sometimes, because you can do I don't know about where you are, but I think you can mail out a sample of your genes, and they'll then bring you back all the risks that you have for certain diseases. But I just don't know. I don't know how reliable that information is.
There is this is very fresh paper. It just came out, I don't know, maybe 10 days ago. It is a research about, generally speaking, genetical issues in tendinopaty, mainly transcriptomics. So not what is in your genes, but what is going on, how the cells are phenotyping. So
right. Okay.
What are the signaling pathways there? Yeah. And what was, for me, it was I don't want to use this term, but some game changer in how can we phenotype tendinopathy. I mean, I think those are my thoughts, of course, only. I think we have those tendinosis hypoxic ones, and this is one point. And another direction, those are those inflammatory proliferative ones, which are very reactive, very easy to react on given factors. The sad thing is, we don't know if those transcriptomics or whatever, I'm not the genetic specialist, if we will find any biomarkers which are easier, like in blood, or maybe something correlates nicely with image or with reactivity, or something which is more practical, more pragmatic. But I don't know, what would you say? But I really look forward to phenotype easier patients, what we deal with in a given situation, because it is more hypoxic on the beginning, and then it goes to more inflammatory one, or differently, it starts with inflammatory and it goes into hypoxic. Who knows? But what would you say on this phenotyping?
Yeah, I think phenotyping is very important. And basically, phenotyping is just another way of subgrouping. It's another way of saying this is a subgroup, this is what we're dealing with. And there's been work recently with Karen Silbernagel's group where they've tried to do some subgrouping. Phenotyping, I think we've got to be thinking about it broadly. So we've got to be thinking we've got a phenotype based on various factors, tissue factors and non-tissue factors. So some of the tissue factors, like the signaling that's happening in the tendon, might be very important. And we're still learning a lot about those. And I think groups like Neil Miller's group, who has done that nature review, they're really leading the way to trying to find treatments that deal with specific signaling pathways. And that is part of phenotyping, but it's also more broad than that. It's also about what other factors are contributing to a person's phenotype and tendinopathy. And it could be for all the factors that we think about when we think about persistent pain. So I think phenotyping could, for example, it could be, does someone have changes in the way they're perceiving pain? So are there changes in pain sensitivity? Are there changes in some of the psychological factors for some people and not others? So I think we need to think about how can we manage individuals better. I think I definitely agree with that, because it's at the moment that probably goes back to your first question when you asked about, what do we do with people that aren't getting better? Well, at the moment, we're a bit like, I'm going to use an analogy now to surgeons. So with surgeons, what do they offer? They offer surgery for everything. And we can say the same as, well, they don't. That's not being fair.
That's true. Yeah. Okay.
They'll probably say no to a lot of patients because it's not a surgical case, and I'm not being fair to them. But that's their treatment. And for physical therapists and physios, our treatment is exercise and loading. Well, some might say that it's also manual therapy, and that's very true as well. I think, but what we need to do is broaden how we manage these people, and we need to think about all those phenotypes and specific contributors. And we need to learn more about how we can target some of those individual factors to have a better outcome. And that sort of is, I guess, precision medicine, and getting more down to, and precision medicine can be about phenotyping from a tissue or a more broad perspective as well. So that's sort of my thoughts on it. But I think it is it's definitely important to think about.
Okay. So loading. You are a master of loading. Okay. Jedi of loading. So we have a patient, okay? We have a patient. Where to start? Because I'm trying to, let's say, promote a view on this topic that we should, at the beginning, somehow judge capacity. Yeah, this is well-known term, loading capacity, or we can name it differently, but loading capacity from the perspective of intensity, of volume, of frequency, so many other parameters which can influence tendon reaction on it. Yeah. So how do you do it, Peter?
Yeah, I think I take a very similar approach. Very similar approach. So and the term that I tend to use is load tolerance, which is probably the same as capacity in that context. But you're trying to find out what the person can do from a loading point of view, and you're trying to then start at something that is reasonable for them, and then graduate up that loading progression based on how they're responding and how they are feeling about it, how hard it is, how much pain, etc. So I think that is that graded activity or graded loading approach is really important. And I think the things that I tend to see if people maybe not progressing enough, so sometimes they do very things that are very, too not going to stimulate the tendon or the person enough. Sometimes sometimes people don't do it for long enough because they think, the patient doesn't stick with it. They're not seeing the early benefits. So there's lots of reasons where it can become not so effective. But I think I take a very similar approach, and it could be isometric, could be isotonic. When I teach courses, I generally talk about my first phase of rehabilitation is called capacity. So building capacity, and what I talk about in the building capacity phase is doing any isometric or any isotonic loading that you can do in a progressive way. So you don't have to start with isometric or isotonic. You can start with combinations of both. You can start with just isotonic. You can start with just isometric. It's as long as you've found the right stimulus and you progress it from there. So that's the first phase. Then we start to do more powerful activities. So
let's say here for a moment, okay? Because I don't know how it looks like in Australia or in other parts of the world, but in Poland generally, there is still a lot of, let's say, hold on eccentrics, yeah? And I know that protocols are okay, but for a very narrow group of people. And you cannot give the same to the old grandma and the young guy who is sprinting 10 seconds on 100 meters. Okay. So this is crazy. Yeah. So how would you go to that before we will go further into more powerful things, like more reactive, more explosive? So how would you comment that?
Yeah, so I think you have to, as you say, try and think about the principles, not so much the protocol. So the principles are that we need to find a good entry point that's not too painful. We need to progress from there. We need to then think about what they need to do in their life. So if you've got a sprinter with an Achilles problem, you might have to do 2 times body weight in a Smith machine with a calf raise or something. If you've got, say, your 70-year-old who just wants to go back to walking with an Achilles problem, then you might just do the calf raises with 5 kilos at the end. Maybe at the start they can't even do a calf raise, and then you get them to 5 kilos. That could be reasonable for them. So it really does depend, as you say, on the individual, and you want to think about the person, not the protocol, is the most important thing.
Yeah. Okay. So, okay, let's say we've made it with this slow tempo things, okay, without reactiveness, without explosiveness, without ballistic things. Yeah. So all of those very powerful things, we have to, with some people, as you already said, get into those more reactive things. And how are you doing that? So how are you starting it?
Yeah, so this is where there's lots of different things you can do. I generally my rehab progression is the next stage is called force generation. So then I start to do things that are involving more concentric power, so concentric fast movements, and that could be in some of the movements they were already doing and already practiced at. So, for example, doing a fast calf raise or doing something like a fast step up or sit to stand.
But you are trying to do it only with concentric phase? So you are...
No, they do both, but they do fast concentric. Yeah.
Okay, so the point puenta is on the concentric part.
Yeah, exactly. Yeah, yeah. Do real fast concentric, and you can work different parts of the force velocity curve. So you do it with a lot of weight or not much weight. With less weight, they'll be able to do it faster. With more weight, they can do it slower, but still with fast intent. So I work in a phase there, and then lastly, I go to things like hopping, jumping, plyometric drills. But some people also benefit from landing drills, and I find that's a good thing to do in between the force generation and the plyometrics, especially if they've got problems with confidence in landing. So some people find that they have a lot of fear when they're loading it, like in a landing capacity, and we work on that as well. But then the plyometric phase, generally going from low intensity, double leg, then to single leg, and then higher intensity, and progressing that over time. So and obviously, as you said, you're not going to do that for your 70-year-old grandma, but you might do some basic things like some double leg jumps or something like that. So it just depends on the person. People fear. I think people are fearful of damage and further damage a lot, and it's quite safe if you're doing it in a progressive way to be able to progress to powerful stuff.
If you work with those younger people, because there are many younger people and more active, physically active, how would you? I know this is not correct question, but how do you blend? That's first question. How do you blend this slow with fast? That's my first question. And the second one is, how long could it be this reactive, then explosive, or plyometric at the end phase of physiotherapy or rehabilitation? I know it can be very short, very long, but approximately.
No, that's good. That's a good question because I think people tend to estimate how long it's going to take.
Exactly. That's why I'm asking.
Yeah. So basically, it does take sometimes as long as the other capacity phase. So it could take 3 months to do that, and it's a gradual thing. So it's very important to also try and use outcome measures. So you can use basic hopping, jumping outcomes. There's lots of different hopping outcomes that people can use from SCL literature that I use for tendons in the lower limb. Like, for example, how far can someone jump forward? How fast can they hop 6 meters? Things like that can be used.
A lot of functional tests.
Exactly.
Metric functional tests.
Yeah, I also use force plates in the clinic to measure hopping and to measure their ability to produce force in a reactive way. So there's lots of ways we can try and make that more structured, that rehab phase at the end. But generally, the way I mix it in is when they are able to get. I always try and have one outcome measure in the capacity phase that they're trying to achieve. So it could be, for example, if you've got someone with a gluteal tendon, say, for example, or you might be getting them to do a hip abduction, and it might be when they reach a target of, say, 20 kilos on a standing hip abduction pulley machine. Then that for that individual is then the time they will start doing some of the faster work. So it might be force generation and then going into the other stuff. So I always have a strength target that they hit in capacity that is a bridge towards the next phase. And And then the way to mix it in, I generally would do, when they start to do force generation and hopping and jumping, I generally do that 2 to 3 times a week. And then I'll do the other stuff, the strength stuff that they were doing, the capacity, twice a week.
Okay.
So I
And do
reduce
you have, sorry, and because it's a good point to ask that, do you have any ranges about contacts in plyometrics? For example, you start with this, that's the basic thing, and then I go down or up.
Yeah. So I generally start with something with a plyometric program, somewhere around trying to build to 150 contacts. So, and it will depend on the person and what they're doing to a certain extent as well. So say, for example, sprinter will be much less contacts, but higher intensity.
Okay.
Whereas if you've got a middle distance or you've got a long distance runner, then you might go to 150 contacts or even 200 contacts.
Yep.
But generally you're building, say, 50 contacts and then 100 contacts and then 150. So you build gradually over time just to make sure that they're able to tolerate, cope with all those plyometrics.
Okay. Yeah. So let's say, for example, we've got a patient who you are already in this, let's call it plyometric phase, and it aggravates. Yeah. It gets aggravated again. So what are your basic tactics?
Okay, that's a good question. That's a good question. So I think the first thing that I do is when you're entering that force generation plyometric phase, the most important thing is to warn the patient that they will get a flare-up. So you have to cover yourself. It's like insurance for yourself.
Okay.
You have to cover yourself and say, this is going to flare up at some point. And that's normal, because then it normalizes the whole flare up, and then they're happy and they're not so worried when it does happen. Okay. Yeah. So that I think is the most important thing. Then you also have a flare up plan. So something they can do when they flare up, you've got to just reduce the loading by a bit. You've got to then go back to maybe some of the more basic stuff for a few days. And then we just have to monitor and see. And usually if you're incremental with the plyometrics, the flare up should last only about 2 or 3 days. If they've jumped a loss, then it might last longer. And if they are some of those phenotypes that you were describing before, more reactive, more sort of, ones that sort of tend to be pain responders, they might last for longer as well. Yeah, so then again, that's where the phenotyping comes back in again. You've got to know the patient, and that will influence how you progress your plyometrics as well.
Yeah. And okay, we already you already said a few times that we are using the progressive model. So we are progressing the load, generally speaking, the load doesn't matter, intensity, volume, blah blah blah. Yeah. So what is the rule you are using to progress? I mean, is it a stable percent amount time? You are checking some milestones they have achieved, or what's your measurement?
Do you mean for the plyometric phase, or
and the tempo phase also? So the build up,
even running and things like that, or So I don't tend to have any set amount in terms of percentage, or like some people say 10% per week or whatever it is. I tend to, my approach is more of a trial and error approach, but I tend to do very, very gradual initially, and then start to speed up. So it's almost like an exponential approach.
All right.
Where they start very slow, and then as you're getting evidence that they're stable, then you can go faster. So it's that's the approach that I take, but it's an individual approach, but trying to do slow and then fast. And that's what I explain to patients. We've got to test it. After 1 or 2, 3 weeks, if we know that this is good, then we start to go more. So that's what I try and do. So rather than a set 10% per week or something like that.
Okay. Yeah. All right. So I would go back to the beginning for the moment,
Yes.
because I work with very broad characteristics of patients. I mean, I've got those young, very active, and I've got those middle age and older, and I've got those very healthy and very unhealthy,
Hmm.
and also those with
Same with
inflammatory.
me.
Sorry.
Same with me.
Yeah, yeah.
Yeah.
And then,
Yeah.
so what we've talked about for now, it works very well with those more healthy, more young, more physically active. Yeah.
Hmm. Hmm. Yes.
So I still want to. Why I'm asking those questions, because
Hmm.
I'm going through now some let's say review. What are the patient characteristics in research in last 20 years in
Hmm.
tendinopathy? There
Hmm.
are two lovely reviews like that which are touching this problem,
Hmm.
and I have to say hardly and sadly that a lot of what we know
Hmm.
is based on very healthy and generally young people.
Hmm.
And the thing is, all of those things works well, really nicely with younger, more physically active, and generally healthy people.
Yeah.
And do you have any? I'm asking about tactics, not the solutions, not the rules. I mean tactics
Hmm.
with people who, on the beginning or in the middle, get aggravated and again,
Hmm.
or they goes well, go up, bang, and they fell down not for 2 3 days.
Hmm.
They fell down to the beginning almost. Yeah,
Yeah.
because we've got those patients. So, what are your tactics?
That's a good question. I think it's important to reflect on where we are at in tendinopathy evidence.
Uh,
We're really at the beginning of understanding this problem,
uh,
and we don't have answers for a lot of people. And like the ones you're talking about, the ones that are difficult, resistant to the treatments that we offer, we feel very much sort of unable to help some people, and the only thing that we can then fall to or go to is thinking about all the contributors that might be there. And these contributors are things like all the things we've talked about. That could be hormonal, metabolic. They're the big ones that I chase. It could be an inflammatory, autoimmune contributor. It could be many things, but uh, I think the most common ones that I see are metabolic and weight related or hormone related. And then we just need to chase those contributors because they're going to give us better outcomes. So it is very difficult, but the only thing we can really offer those people are things like physical activity intervention. So, for example, if a patient is like that, where I feel they're metabolically driven, I will say to them, uh, any exercise that I give you is not going to be as effective as you improving your fitness and your health. So if that's the driver of your problem, I can't help you with exercise that I give you unless we deal with that first. So then the shift of the treatment goes to, okay, this is the key problem. We need to deal with this problem. And that's where I get help from other colleagues like exercise physiologists, and they'll sign up to exercise physiology for 2 3 months, 4 months, and they'll do that 3 or 4 times a week. And we've had really good success with some people. But there's a very big component of the person needing to engage with something that's very hard. So, and some people just don't have the time or the capacity to do that. So it can be challenging. But I completely agree. We do not have answers for a lot of people when it comes to treatments, and it's frustrating as a clinician to be able to be so blunt in the things we can offer. And that's where we need better precision about how can we deal with these problems.
yeah. My big problem, or I see that problem in Poland, is that tendinopathies, enthesopathies, tenosynoviopathies, whatever, whatever we will I will say here. People think that it's a easy problem, fast fix. It should last 4 weeks, 6 weeks. It will be fine. And it's really difficult to explain people that this is one of the most common problems in your motion system, let's say, yeah, or musculoskeletal system.
Yes.
It's from the, let's say, definition, it's a long-standing problem. And really, it's hard for us to, as we already said that, to say how it will end up. I mean, we don't know where we will go. We don't know the result, and it's hard to guess. Yeah. So you agree with that?
Absolutely.
And do you have those problems with understanding of tendinopaty in Australia, for example, or do you see that in around the world when you're traveling?
Without a doubt. Everyone's struggling with the same things. Everyone's struggling with the same things, and we all do similar. I think we all do similar things to try and get these people better. And it's we all struggle with the same problem. So we need better understanding of the individual complexity. And as I mentioned earlier, some groups are working towards that. And I think Neil Miller, Silbernagel, some other groups around the world are probably doing it as well.
Yeah. So my last question to you, Peter. Can you tell us about 3 things which you would wish us and yourself in the world of tendinopathy problem to come faster than slower?
Okay, that's a good one. I would probably say better global understanding and education about tendinopathy. So we've had lots of global campaigns about pain. It'd be good to have global campaigns about, the basic things like pain and pathology that we've talked about today. That would be really good because patients often get confused and very worried. The second thing would be trying to understand also, as we've talked about today, the individual contributors a bit more and how we can deal with them. And the third thing would be, I guess, thinking about, what's the third thing? The third thing I'm going to say, a very fanciful one. I'd like to maybe someone like Neil Miller or some other group to develop a magic bullet. So some sort of tablet or some sort of something, machine, whatever it is, that we can just get people better. And that would be great, but that's not going to happen.
Yeah, that would be great. I think I will be a sand if that moment will come at all.
Absolutely. Yes, I think we all will be.
Peter, thank you so much for your time. It was really a pleasure to have you. I hope that was the first time. Maybe in coming years that won't be the last time.
Yeah.
And I hope there will be a day you will visit us in Poland. I hope.
I'd love to. Thank you very much. Thanks for having me on. It's been a pleasure.
Thank you.
Thank you.